Good afternoon, everyone. I request our chair, Professor N.V. Madhuri, please come on the stage and join us. I also request our paper presenters, Dr. Shazia Farooq Fazli, Akansha Roy, Dr. Visakha Jay, Dr. Diksha, and Manisha Datta, please join us. I welcome back all of you to the afternoon session of this today international seminar on politics of gender, health and digital initiatives in India, organized by the Department of Center for Women Studies in collaboration with the Department of Sociology, Maulana Azad National Urdu University. My name is Muhammad Altaf and I am a research scholar from the Department of Sociology. I am honored to coordinate this part of the session. Before we begin, I would like to introduce you to our chair, Professor N.V. Madhuri. Dr. N.V. Madhuri is professor in the Department of Anthropology at the University of Hyderabad with expertise in development anthropology, tribal development, gender and local governance, gender mainstreaming in rural development, gender budgeting, self-help groups, and women empowerment. Her research explores rural women-based livelihoods, gender and nutrition, promotion of micro enterprises and entrepreneurship development among rural women. She has published extensively in reputed journals and contributed significantly to anthropological discourses through her teaching and fieldwork. Dr. Madhuri did PhD in development anthropology from Osmania University and is actively engaged in academic and community-based initiatives in India. In this session, we have a lineup of four eminent speakers, Dr. Shazia Farooq Fazli, Akansha Roy, Dr. Visakha Jay, Dr. Diksha, and Manisha Datta. Without further delay, I would like to request our chair to take the session. Please share the reminders about the program. Over to you.
Good afternoon, Dr. Shahida, other faculty members from MANUU, the presenters, and also the audience. Before we request the presenters to make their presentation, I would like to share a few of my thoughts very briefly. I'm sure most of the localites who are here, they must have heard about a series of incidents which have happened in a fertility clinic a few weeks back in Hyderabad. And this has raised a lot of debate on how ethical are these practices which are happening when it comes to usage of technologies and women at the receiving end. It also raised a lot of debate on what are the positive impacts of usage of technology on women and what are the negative impacts of this usage of technology. And I've been listening to some of the presentations in the morning session. So when it comes to digital health technologies, the DHTs, which we call, we have been hearing about a lot of initiatives. For example, the telemedicine, which takes us to the remotest corners and how women can access health services to these telemedicine. We have been listening about various mobile devices, the wearable devices like smart watches, which we very frequently come across in the urban areas especially. We have been listening about digitizing the health records, a plethora of health information, how it is being digitized, and how this kind of health information helps us in tracking the health issues which we ourselves have as individuals. We have been listening to 3D printing, which helps us in prosthetics and which helps us in implants. We have been listening to robotics, how robotics help us in minimum invasive surgery. So n number of initiatives. We have been listening to bioinformatic tools, how they help in tracking the genetic disorders. But then, if you look at all these digital health technologies, they offer a lot of opportunities, no doubt about it. They also empower women by giving access to a lot of health information. Yeah. So digital health technologies offer us a lot of opportunities. At one hand, But on the other hand, what are the kind of challenges do they pose? Some of the papers have very vividly brought out that kind of challenges, especially in terms of access. Do we really have access? Do both men and women, do they have equal access to these digital health technologies? Not just in urban areas. If you go to the rural areas, if you go to the tribal areas, the digital divide between men and women in terms of access is increasing. So how do we overcome such kind of existing inequalities when it comes to issues like digital literacy? Are we both equally digitally literate? Do we have that kind of digital skills? Where do we stand when it comes to digital skills and digital literacy and the awareness about usage of these digital tools? These are some of the challenges digital health technologies pose before us. And added to access, we also have issues of affordability. Are we equally affordable, both men and women, boys and girls? Are we able to afford these kind of digital tools? N number of mobile apps are being promoted and being marketed. But how sensitive are these mobile apps to the specific requirements of women when it comes to the design part? Who are designing these kinds of mobile apps and mobile tools? How many women are entering into the STEM areas? So it's these people who enter into the STEM areas who tend to design the digital tools. So when the inequality starts at the entry level, when it comes to the design level, are they culturally sensitive? Are they designed with a gender lens? So these are some of the issues when it comes to the design part. And when it comes to the privacy part and the security part, so I mean, data analytics have a lot of data at their disposal. Whether the data which is at their disposal, is it gender disaggregated? Do we have such kind of trend to analyze from a gender lens? Again, that is also another challenge which we have before us. So issues of privacy, when so much of information is available at hand, does it really guarantee any kind of privacy and security to the women, especially women from the marginalized and the most vulnerable sections of the society? So how are they being used? I mean, the kind of fertility clinic incident which happened in Hyderabad again points out to all these kinds of issues. So I'm sure this particular panel and session will discuss all such kind of issues. So I see 4 presenters who are present here. We will have 10 minutes each. And in that 10 minutes, try to focus more on the findings, more than the review of literature and your objectives, right? So that will give, that will throw a lot of light on what you really want to say. And that will also initiate debate, right? So 10 minutes for your presentation, and then let's have a very common discussion after the end of all the presentations are over. We'll devote maybe for 10 to 15 minutes of discussion based on all the 4 papers. Is that okay? So let's start the presentations. I would request Dr. Shajia first to present her paper on gender and incarceration. Yeah, sure.
So, respected chair of the session, my dear friends and students, good afternoon, all of you. It is privileged to have this opportunity to discuss the issues. Those are very much related with the reproductive health and the politics of gender. I sincerely thank Professor Shaida ma'am and Zia sir for selecting this important topic for this conference. Actually, where's the PPT? नहीं, वहाँ से बोलिए। Actually, I want to discuss the issues. Those are very much related with the prisoners or incarcerated women. So I want to draw your attention to the fact that there is also a group of society who are stigmatized. Why they are stigmatized? Because they are in jail, and we think that these all are the bad because they has committed crimes. That's why we don't give importance to any of their important issues. When we are please change the slide. When we are talking about the issues, those are very much neglected, but these are the crucial issues and critically concerned about the women. We always think that women's health, particularly reproductive health, has traditionally been neglected both by society at large and at times by women themselves. This long-standing oversight underscores the urgent need to address reproductive health as a central component of public health and gender equity. When we are talking about the reproductive health, women who disproportionately bear the burden of reproduction biologically, socially, and culturally. Consequently, there is a compelling case for ensuring that women have greater agency and autonomy in matters of fertility and reproduction. Scholars such as Cleland Hopkart have argued that societies with strong matrilineal traditions, yet where women are denied equal public or economic roles, tend to resist reproductive change more than egalitarian society, and this suggests that the enhancing women's status in both private and public spheres is essential to achieving meaningful progress in reproductive health and rights. When we are talking about the global framework, always we start from the Alma Ata Declaration from 1985 and ICPD 1994 and Beijing Conference 1995 defined reproductive health as complete well-being in all matters related to the reproductive system. These frameworks underscore individuals' right to reproduce, choice, autonomy, and access to care at all life stages, yet these rights are scarcely extended to the incarcerated women. And when we think about the global gaps in the prison healthcare system, there is a quote: to imprison a woman is to remove her voice from the world, but many female inmates have been silenced by lifelong before the transport van carries them from the courthouse to the correctional facility. Willingham highlights the silencing and systematic oppression that women experience throughout their lives and during incarceration. The intersecting of gender, incarceration, and reproductive health remains an under-researched yet urgent area of inquiry. WHO Health in Prison Project 1995, promoting the integration of prison and public health systems, actual implementation remains weak. In many countries, especially in the global south, women prisoners struggle with healthcare infrastructure and lack of access to even basic reproductive services. Women gender-specific needs such as menstrual hygiene, pregnancy care, contraception, abortion access, and STI treatment are frequently overlooked. When we are coming from the theoretical framework, this study grounded in the critical feminist rights-based theories such as the Wollstonecraft's in limited reproductive rights by the early 20th centuries, and Simone de Beauvoir focuses on the health-related operation of women. The movement brought women's health, especially reproductive health, sexual rights, and access to care, information, public and political conversation. Because intersectionality is the part of the prison, so the Gayatri Spivak pivotal question, can the subaltern speak, underscore how incarcerated women are doubly marginalized, first as women and second as prisoners, rendering them voiceless within carceral systems. And Kimberly Crenshaw theory of intersectionality, further expanded by Collins and Bilge, helps analyze how overlapping operations, gender, race, class, and incarceration shape these women lived realities. These frameworks expose the silencing mechanisms that deny incarcerated women their reproductive rights and agencies. And when we are coming of the moral and social imperatives, Nobel laureate Amartya Sen has argued that a society's development must be evaluated by the health and the dignity of its most marginalized members, not merely by economic progress. And in this light, prison reproductive health is not just a public health issue, it is a reflection of broader societal injustice and a violation of human rights. Please. हाँ yes 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 आगे और आगे कर दीजिए yes I'm coming on the graphs only yes please और कर दीजिए आगे और ये these are the human rights standards I am not going to discuss these yes please और आगे कर दीजिए और this is the study area we have selected 2 jails Aligarh and Lucknow district jails Uttar Pradesh in India yes next slide please yes 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 women only in the prisons incarcerated
all women prisons are there.
all women prisons
Are they up to?
yes in both the jails we have studies in both the jails
All women.
oh, yes only women no these are the district jail and the central jail of the Lucknow but we have selected the women
Okay, fine.
in that particular jails so reproductive health of the respondents is here you can see the special care for pregnant women, special diet, iron folic acids, folic acid tablets, and all the above. These things are you can easily see the things, those are not provided by the jail staff to the pregnant women. And because of this, her mental health issues are also the great concern in that particular system. Period of detention in Aligarh and Lucknow jail. This is the, please change the slide. This is the period of detention. Some less than 6 months, 1 to 2 years, and 3 to 4 years, and 4 years above. Usually, women are living 1 to 2 years, and they are not getting ANC services and PNC services within the jail. Actually, we have skipped the slides of the provisions. Those are the Mullah committee reports, and so many provisions are there. Those are provided by the government for specifically for the women. Those are living in the jail, and they are having rights about. They can easily get the ANC services, PNC services, and the medical female practitioner should be there, but these all things are missing within the jails. I will give you the answers after the presentation.
There were life terms also.
Yes?
Life term also. For whole life they'll be
No, they are not whole life. They are the under trials usually.
Okay.
Yes. I have also mentioned the number of years of detention because yes. So the next slide, please. A place of delivery, it is a very important part when we are talking about the reproductive health and the pregnant women. Usually, they are taking these pregnant women to the nearby government hospital, or sometimes it will quite difficult for them to take these pregnant women to the hospital, and all that the pregnancy and delivery is not in the hands of the doctor, and the so much of rules and regulations. And one or two incidents we had found in the jails that the delivery was there in the jail in itself. So this is the big question: what kinds of things we are providing to the pregnant women. And mode of the transport, only there is one mode of the transport, that is the ambulance, which is provided to the jail staff for these. And these are the this is the place of delivery and the mode of the transport. These all are related with the pregnancy part, ANC part, and PNC part. But the other things, those are also is the part of the reproductive health, because we are only taking these parts. These are the part of the reproductive health. But other, please change the slide. Uh, Other things are also the part of the reproductive health. These are the sexual transmitted infections, STIs, and all the things. Those are actually, they don't know about these kinds of infection. And if you are going, if you are asking about these kinds of infections to them, so they are not having, they are not getting any facility about knowing the things, or about getting treated in the jail system. And the another thing, having these are the infections criteria, chlamydia, gonorrhea, they don't know about. Please change the slide.
Dr. Shadia, 2 more minutes.
Okay, I will. These are the other STIs, and one more thing is the urine and blood test. These things are not uh, provided by the jail staff to the pregnant women or other women also for their pregnancy test, because you all know so many things are going on within the jail. Those are under the table. Those are not in the open.
Spell out the disease, right?
Yes.
How did you syphilis? कैसे पहचाना?
Ma'am, I will give you the answer after the and knowledge of the HIV, STDs, and RTIs, and they, please change the slide. They are not having any idea about this HIV, STDs, and RTIs. They are not, and please change the slide. This is the qualitative data analysis I have done in NVivo, and this is the respondent sentiments that the violence and the so many things are there. Those are going on in the within the jail, and these are from the case studies which we have taken from the jail. And please change. This is the this data is from the case studies also, that the all the women are saying the negative aspects of all these things. They are not having any kind of knowledge about the STIs, STDs, HIV/AIDS, and they are also not getting the things those are meant for them. Those are the rules and regulations are clearly speaking that the lady doctor should be there, the proper diet should be there, but they are not getting the things. And because this is on air, so I cannot talk so many things over here. So these are the cases which I have taken. This is the 10 cases. And please change the slide. Yes, this is the for first thing is the focus group discussion, which I have done in the both the jails, and they are here. You can easily see that the negative aspects are uh, uh, more clearly depicted. The negative aspects of the jail here in all the slides you can see. Please change.
Dr. Shadia, I think.
Yes. Results and discussion only. I am. But within, so this study reveals several concerning trends and challenges faced by incarcerated women, particularly in the context of the cultural norms, economic dependence, and prison conditions. A majority of the women are housewives, fully dependent on their families and lacking agency to assert their rights. A growing number of young women are involved in serious crimes like murder, often targeting husbands for family members, which indicates extreme levels of harassment, driving them to act without considering consequences. Older women are predominantly implicated in dowry related offenses. Women prisoners face numerous hardships, including overcrowded barracks and restrictions of voicing grievances against jail staff. Harassment is pervasive with inadequate food, poor hygiene, all the things are there. And pregnant inmates face several neglect with limited access to lady doctors, antenatal, postnatal care, and nutritional diet. And the last slide, please. Pregnant women are transported to hospital for deliveries in inhuman conditions, often with handcuffs or iron chains around their bellies and hands. Delay in care sometimes result in childbirth within the prison itself, highlighting the lack of timely support. Prison harassment includes physical, psychological, and social mistreatment by both co-prisons and staff. Okay, thank you so much.
I think many of you seem to have some questions. So maybe let's take the questions even before we go on to all other presentations. So very quickly, can somebody give a mic to her?
How many inmates were pregnant at the time of the study?
Six.
Time period of the study? How did you get access
Yes,
to the
yes,
jail?
yes, yes, yes.
I'll be very quick. How did you get access to the jail?
Yes,
Finally, were there reported cases of miscarriages happening
Yes.
In the jail because of the bad treatment?
Yes.
There's a time of actually we get permission from the
commissioner of the jail from Lucknow, and after that only we can conduct the the survey in within the jail. And so many restrictions are there. We cannot take our phone, we cannot take anything inside the jail. Because of that only photos are not here, and we cannot speak so many things in this particular platform because of the ethical consideration which we have signed when we are going to collect the data within the jail. Yes. And the another thing is the 180 respondents we have taken. Some six women are pregnant in the jail, Aligarh jail, and 10 were pregnant in the Lucknow jail. Yes, and one stillbirth and one miscarriage was there. Yes, and reproductive health problem because it is the age of the 15 to 49, menarche to the menopause, WHO guidelines. We have followed these guidelines only. We were strictly adamant on these guidelines. Yes, and the so many things, those are very, very alarming, that if so many rules are there. Mullah committee report is there in which they will get the proper diet, egg and the diet for the pregnant women, but they are not getting these things, or if they are getting, they sell their diet for the money, and they are mopping the floor. They are mashakkat word is used in the jail for these purposes. They were doing these kinds of things in the jail, and it is so many things are there we cannot discuss here openly because of the ethical consideration. Thank you so much. Yes, ma'am.
We have conducted in 3 jails, not one. All female jails. Girl here and somewhere else. Okay. And there are 2 things which I would like to ask. Since you have interviewed the women who are staying with the male.
Yes, yes, yes.
तो आप देखा कि प्रेगनेंसी कब हुई है उनकी, प्रेग्नेंट बनने की?
Ma'am, actually, this is also the question, and I have one slide is there, urine test. Yes. So, ma'am, this is the question. Some alarming things are also there. ज्यादातर जिन 6 को हमने लिया है वो प्रेग्नेंट थी जब वो देन they came they were pregnant, but so many things are there. Medical harassment, sexually harassment is there, and these things. Yes, and so many studies are based on this. One study in which they are saying my body is not my body, it is open for all. So these things, this is the study of one foreign thinker, and these things are there. Yes, and
sorry to cut you short. The people belonging to the low caste.
yes,
टॉयलेट धोना है, कोई ब्राह्मण या मुस्लिम नहीं धोएगी. एससी को लगा.
yes, ma'am. I have used the intersectional approach over there, which slides I have missed, the determinant slides and all the slides I have. Yes, this inhuman.
Our girl was interviewing. Suddenly कोई आके बैठा. उसके बाद he said, okay. After that, I tell you, when she entered, they were washing the chair.
to write before the officer in charge. क्या हुआ है? तो बोले one of the inmates happened to be SC. उसने उसके ऊपर बैठ गई थी वो. So it is untouchability. We have to
But
watch
these
it.
things are there.
So I think our report should have all, not to conceal, Shazia, not to conceal. See the men's eating the grass. Girls are being impregnated while they are in prison.
Yes,
That's
yes.
very,
These
very
things are
important
going
that
on.
we take
Yes,
care.
these things are
Plus, sexually transmitted diseases cannot be waited for treatment. It has to be quickly attended
Yes.
to. Are they doing that?
No,
And how
no,
they got those diseases?
Only once in a week, one medical doctor, female medical doctor came in the jail, and then after some, actually they are so much ignorant, not having
They
knowledge
can't
about
afford
the
to ignore.
Ma'am, I think time is running out. Shalia, one last question. Okay, one last question. I think there is one hand there. Very quickly,
Yes.
because she is available during lunchtime, so you can have a discussion with her, and because it's a debatable topic, I think let's move on to the next presenter. Thank you, Dr. Shajia. I would now request Dr. Akansha Rai. Okay, yeah. Akansha would be presenting on the gendered reading of digital health initiatives in the context of Uttar Pradesh.
Yeah, good afternoon, everyone. So the topic of my presentation is the gendered reading of digital health initiatives in the context of Uttar Pradesh. And I would just make few clarifications before proceeding. Though I know gender is a fluid construct, but for purpose of this study, I'm using gender as a binary construct when analyzing government data. Also, second, my research is not directly based from the field of digital health initiative because my PhD topic is not directly related to digital health initiatives. So it is basically dependent on the NFHS as well as Oxfam report and various scholars' engagement with digital health initiatives. Though at times I have brought narratives from my field, but for the purpose of inclusion of basically phones as well as for basic access of basic health services, but not directly to digital health initiatives. Yeah. Government survey. The word itself could have a frightening experience for many, specifically for the marginalized section of society. Remembering visiting my field in month of July 2021, which was immediately after the pandemic, I went to Khairatabad in Mau district, an area known for Muslim women engaged in powerloom weaving in their households. As outsiders to the field, we as researchers often enter through links into the field. But a tiny miscommunication brought up the fear of the word survey very eloquently. As the link through which I went, though explained the purpose of my visit, but somewhere the families understood the purpose as solely survey. The older woman of the family whom I met asked me, quoting her, क्या आप सर्वे करने आई हैं? नहीं was my answer. आपको पता है आप ये कॉपी लेकर अगर गई यहाँ किसी के घर, ये लोग आपको सर्वे करने वाला समझेंगे और कोई जवाब नहीं देंगे या गलत जवाब देंगे. उन्हें डर रहेगा आप सरकार की तरफ से हैं. Now, what was the basis of this fear? So the apprehension towards survey at that time was rooted in the penalty charged to the powerloom operating households, as after UP government removed electricity subsidy and few weeks before a survey was done in the area and residents were accused of stealing electricity, though later the subsidies were revoked and even a penalty was removed. But was their fear legitimate or illegitimate? Numerous studies have shown how data surveillance often becomes a tool of control, coercion, and violence. Sneha Krishnan examines in her article how women's bodies are surveilled through disembodied data practices in India. The author discusses the arrest made in early Feb 2023 in Assam linked to child marriages. And in these cases, digital health data was used to criminalize women. Around 3,000 people were arrested. It depicts how such surveillance disproportionately affects women from lower caste and minority religious groups. Evidently, in this case, the state has relied on personal health record to ascertain the age of the mother at childbirth, arrest their husband, in-laws, and subject them to imprisonment. In all cases, these women belong to Muslim families. Now, one of the major steps toward digitalization Indian healthcare came under this Ayushman Bharat Digital Mission. There were two key components. One was digitization of medical data by creating Health ID, HPR, HFR. Second was for employing technology to deliver healthcare services through telemedicine, U1 portal, as well as e-hospitals. Now, in context of Uttar Pradesh, there were certain portals as well launched applications like comprehensive digital health application for frontline workers, applications, Anmol application, and e-Kavach application. So basically, they would track the pregnant women, their prenatal, antenatal, and delivery services. Now, who are the workers who will fill? These are the frontline workers who will collect the data at the sources, basically Ashas, ANMs, and Anganwadi workers. Now, the digital health initiatives appropriate women bodies by characterizing their age, marital status, number of pregnancies, social status, and this data is entered on the ground by Ashas and AW, Anganwadi workers. Now, the various welfare entitlements or financial incentives can only be assessed by after uploading these details. Both the mother and frontline worker cannot benefit from the financial incentives that encourage hospital deliveries under various yojanas, like one of them Janani Suraksha Yojana. Now, so another tool was digitally empowering frontline workers. Now, who was the most burdened with these digital initiatives? On whose neck is the responsibility of digitalization and on what cost? Ashas and Anganwadis and ANMs face the burden of digitalization, where Ashas mostly come from low socioeconomic backgrounds of they belong from Dalit Bahujan communities. Now, Ashas are also as the workers most exploited in terms of over burden of work. They receive a remuneration of some 2,000 to 2,500 rupees, and the other payment system is incentive based on the task they perform. They are the one burdened with interacting people, facing their wrath sometimes, pay the transportation costs themselves, and keep balancing the domestic as well as their professional needs. According to Rati, undeserved settings such as rural and hard-to-reach areas lack the digital infrastructure needed to support and even maintain these basic electronic health records. Yeah, okay. So, yeah. So, Kulail argue for the digitally marginalized. According to them, existing studies have stressed the importance of digital inclusion, but the perspective and experience of individuals who are digitally marginalized are often overlooked. So the attempt was made here to understand and recognize the digital marginalization from gendered lens. So various Oxfam reports says that 70% of population in India is still poor or no connectivity to digital services. Indian women are 15% less likely to own a mobile phone and 33% less likely to use mobile internet services than men. So, and internet is often perceived as a risk to the traditional social order or seen as unsafe for women and girls. Male gatekeepers control or restrict access to devices and the internet for many women and girls. Chaudhary and Binder writes this. Now, even from the field where owning a smart, we see a stark difference where basically for 80 artisan households were actually study was conducted, a qualitative study, where in Muslim Ansari community, where the men identified them as the waged classes, the women didn't own any mobile phone, and men also didn't own smartphones, rather they had normal mobile phones. Whereas the Hindu Maurya community, since their economic classes were supplemented by their agricultural income, men did own smartphones, while women mostly owned mobile and relied on men for phone recharges. Now, basic health services problem which people faced was though public hospitals are subsidized, they do provide a treatment for minimal rate, but the narratives were आने जाने में ही एक दिन की दहाड़ी चली जाती है, इतना दूर है hospital. Whereas for women generally travel with either a male chaperone or an older woman, making the cost double for them to access basic services. And so it is unclear how telemedicine, rather than brick and mortar hospitals, better transportation facilities will address the problem of access to healthcare in the remote part of India, where internet shutdowns are remote and routine. So the conclusion is the privileged can capitalize easily on these initiatives, making the gap and divide starker, while relatively privileged people are protected from certain inspection in terms of privacy and data surveillance, can access high quality treatments, whereas the poor and marginalized community and women who depend on public health care are subjected to rigorous surveillance and monitoring. Though a point that not in the digital era everyone is in surveillance of data, but still the underprivileged are more. Then these initiatives such as telemedicine and e-hospital cater to a specific group of people who are digitally literate, English speaking people with a smartphone and the internet. The apps are not designed keeping in mind the health literacy and accessibility need of communities, so this can somewhere lead to exclusion. And yeah, so these advancements are not equitably available to all sections of population, particularly the marginalized population like that of older people, women, socially and economically disadvantaged. Thank you.
Thank you, Akansha. Any quick questions for Akansha? Yes, please.
Good presentation. As you said, Uttar Pradesh is based on the caste, and the ASA worker also facing the problem. Then, how do you deal with these institutional issues? Because it is a caste base. Because most of the ASA they didn't allow the locality to enter going to their home.
So basically, if ASHA workers are themselves coming from marginalized backgrounds, so we also need to understand one aspect. If particularly in a Dalit locality, if we have a Dalit ASHA worker, she will have a, just not assuming, but she will have a better access, definitely not better access to a privileged household, but in her own community, she will have better network. That's why the way ASHA workers are chosen, it is from the same locality so that they have more familiarity with the women and they have more good network or access to the women in the... Definitely.
Except the Musar community.
Definitely.
Except Musar community.
I think this kind of discrimination is more faced them when they work in urban localities, where there are instances where when they go to urban kothis and all, even if they're collecting data, they cannot access. Even in villages, these kind of thing happens. But then what happens? There are ANMs and there are ASHA, seniors in that Sangani, which are generally from by promotion. These are upper caste women who appropriate those kind of positions. I think that kind of, and this is just from secondary data, since I have no personal experience, I cannot again claim on what kind of what kind of marginalization they are facing while working.
Any other question? I think be it prisons or be it Uttar Pradesh, remote regions, the gender intersectionalities are present everywhere. That's a deep reality and then very deep rooted. So addressing it institutionally or policy-wise, program-wise is not easy. Anyway, let's move on to the next presentation by Dr. Vishakha Jha. Dr. Vishakha will be presenting on role of women diplomats. This is quite interesting in India's health diplomacy and digital initiatives.
Greetings to all of you. This is Dr. Vishakha Jha from Dalbagh Educational Institute, Dalbagh, Agra, Uttar Pradesh. And today I'm going to present my presentation on a topic, the role of women diplomats in India's health diplomacy and digital initiatives. So basically, I'll look towards that what are the roles and representation, what are the contribution they have made when it comes to the foreign policy or foreign services, and specifically India's health diplomacy and digital initiatives. So firstly, we'll understand that what exactly the meaning of, can we have a next slide please? Yeah, so firstly we'll understand that what exactly the meaning of India's health diplomacy. So it's actually a process or a practice where two or more than two countries or international organization, regional organizations, the guys are coming together and negotiating on the issues of health, and they're trying their best to resolve it, because as we guys are familiar with this fact that we are living in a globalized era where countries are interdependent on each other, interconnected with each other. So that's why the one thing is happening in one country, it's going to affect, and it is affecting the other part of the country. So that's why now it became a global point to discuss that what exactly the issues are going around the world and how we can resolve it. In this, how we do this thing, what are the diplomatic tools or works we do. So in this, we using the health aid or medical cooperation, pharmaceutical supply or health technology collaboration the countries are doing in between. So this is the health diplomacy, and under this, as we are living in the digital world, so in this particular diplomacy, we actually trying our best to connect the medical facilities to the digital ones, so it will be reachable to all of them. Can we have a next slide, please? Yeah, so this is actually, these are the initiatives taken by during the, especially during the COVID. We can see that vaccine mandatory we have done, like India done, and India supplied so many vaccine to the South Asian countries and EU and SAARC regional organizations too, and CoWIN platform. In that, the guys come together and make their collaboration. They discussed about it, and National Digital Health Mission India talked about this thing in global platform. Can we have a next slide, please? Yeah. So now I'm going to talk about that. How many women diplomats are participating in India's foreign policy? Next slide, please. So here I took firstly I'll show you the global data from Inter-Parliamentary Union 2023 data. Next slide. Yeah, here you can see the global, even though women are covering half of the world population, but when it comes to the representation in their politics, especially both the houses, the global data is showing from Inter-Parliamentary Union 2023, only 26.5%. And specifically when we'll get into the Asia, we have only 21.2% in lower house and 19.4% in upper house. Total is 21 only. So you can see the less representation of women in their houses. Next slide, please. Yeah, here you can see the representation of women in various political and foreign affairs. Specifically, if you can see the head of the states, only 11.3% overall global, and head of the government 9.8%. So likewise, you can see the percentage. Next. Yeah, here the global percentage shares of ambassadors 2024. You can see here that I was just seeing in 2023, I was hoping that at least 1% will increase, but earlier it was 21% women ambassadors are sharing the global platform, and still in 2024, it's still the data is similar, like the male ambassador is more. Here ratio in 2023, you can see the blue color is representing the male ambassador across the world, and when it comes to the brown ones, it's for a female, it's less. Next. Here the region wise I have shown the representation of women diplomats. Asia, you can see the very less, only 14% women diplomats are representing their country. Ambassadors are representing their country across the world, so it's again less. Next. Yeah, now I'm getting into my topic, that's the Indian women participation in India's foreign services. From the beginning, zero, but it improved from the ancient time to till now. We can see the data or the representation of women diplomats, it improved, but when it comes to the equal participation, the 50-50, that we cannot see up till now. Next. This is from, again, the Women in Diplomacy Index, the previous one, yeah, report. Next. Yeah, this is the similar site, like from similar report. I took this data. In 2023, you can see the comparison, only 2% have increased. Next. Here, this is the overall percentage. Next, please. Here, this is the report given by one of the think tank, name is Kuberian Initiative Report 2023. It shows that the total division is 64 and man is, occupying 52, and for women ambassador in Ministry of External Affairs it's only 8. So you can see the disparity. Next slide, please. Yeah, here in the same report, it shows that obviously the men is representing more and women percentage is less when it comes to the promotion and ambassadors. Next slide, please. Yeah, so these are the representation. Next, please. This is the report from the Global Gender Gap Index 2006 to 2024. I showed that the ranking of women, India when it comes to the women representation. Next, please. Yeah, this is the ranking. Next. Here, when it comes to the Prime Minister, only 1 out of 14. Minister of External Affairs, 29, and the Foreign Secretary, 3 out of 31. So you can see the disparity. Next, please. Here, I showed that the contributions of women diplomats when it comes to the health, diplomacy, and digital initiatives, Vijaya Lakshmi Pandit, she represented in UNO, and she made a very nice contribution in that when it comes to the women's right and public health after the World War II, when we can see. Next, the Hansa Mehta, she contributed. I would like to quote what exactly she made the transformation when it comes to drafting the Universal Declaration of Human Rights in 1948. She actually changed. There was one quotation that was written over there that all men are born free and equal. She changed that all human beings, instead of man, all human beings are born free and equal. Next, please. She's Vijaya Lakshmi Pandit, representing in UNO. Next. These are the contributions. Next. Mutamma. She made a very great contribution when it comes to the rights and representation of women in Indian Foreign Services. Next. The current ones. Next. These are the contributions. Next, please. Next. Yeah. Here, I would like to show that what are the factors which are affecting. So I am quickly summarize this thing, that the first thing is the gender, the concept of gender. As in our previous lecture, we guys were hearing that the gender is actually socially and culturally created by the society, which is discriminating in its nature. And that's why it is becoming a kind of barrier in front of women diplomats to represent in this platform. Then the family responsibility, patriarchal society, and family responsibilities. That even though it's actually not a problem of women diplomats, but actually this is a challenge before every woman who are participating professionally, that how they can balance personal and professional life together. Because even though we guys got the chance to get into the professional stuff, but we are not completely free from our personal responsibilities, and ultimately we should have to balance both the things together. So that is a biggest challenge before women diplomats as well as all women. Next, please. Next. Recommendation, the main thing I would like to say that there is a need to introduce feminist foreign policy which will talk about the equal participation of women and the promotion, the treatment. Actually, we have the laws. When it comes to giving them a laws, we have, but when it comes to the practical implementation of those laws in the reality, there we are lacking, and that's we have to work on it. And the role of media for advertising women, to enhancing, to showing that yes, they guys are doing well, and promoting them. So that is really required. Next slide, please. Next. But ma'am. Next slide. Yeah. In conclusion, I would say that from the ancient time to till now, even though the percentage of women diplomats has increased when it comes to India's foreign policy or services, but still the guys are not participating 50%. The guys, their number is still less across the world, not just a point of India, but even in US also. We can't see even up till now, even a one single president, female president. Recently, we got one vice president in the USA. So this kind of disparity lies, and we need to work on it. Then we can, make a wider concept, and we can get into the exactly the real life. That's it. Thank you.
Thank you, Dr. Vijay.
Thank you.
One maybe before you address the
Questions.
question. One quick question. The entire findings which you have been presenting, they are based on the report, right?
Yeah, they are based on the secondary data. That's the report of, global, like the UN report, and because Interparliamentary Union, that is introducing by the UN report actually, and few are Indian, like Cobarian report, that is Indian think tank, and that Women in Diplomacy, that is actually UAE, their think tank. They gave this report.
So any quick questions for her?
Thank you.
Dr. Vijay?
Thank you.
Yeah.
These diplomats are elected or selected or appointed?
Actually, these diplomats are, the guys are getting into the exams, the UPSC, and then through that, the guys are getting into the, in the diplomacy, like the foreign services.
So it is a selection process. So how you look at gender into that selection process?
That's
Because
okay.
it is all
Nice
the
question.
subjects.
Nice
So
question.
your research has to be something.
Yeah, that's why here, if you saw my data, then you must see that I talked about the ambassador, the women ambassadors. I'm not saying that there is equality when it comes to the participation in exams. The guys are participating, and the guys are representing, and the guys are getting the selection. But the two constraints are there. First, how many women are participating or reaching in that particular exam? First thing, society are supporting, society or families are giving them a chance that you should have to get into that particular challenging role as a women diplomats. After the marriage, how you will balance both the things together? Because it is, of course, when you are getting, because during my PhD, I did my PhD in this only, and during my PhD, I took a few interviews, 10, 12 ambassadors interviews, and the guys told me that families are not actually, the guys have scared that how after the marriage you will balance the things. So first constraint from the family and the society, the patriarchal society, first thing. Second thing, I showed the data that showed that the women ambassadors, it means that diplomat getting into as performing as a IFS officer, that's fine, but when it comes to the promotion, how many of you getting a promotion? How many, states giving you a chance to represent yourself in the global platform?
Let's also take one more question.
Yeah.
You might have a similar answer.
You have taken diplomats. And how many of them are actively participated or done in the digital initiatives? Their work, important work.
The Vijaya Lakshmi Pandit, she made a great contribution. Recently, Ruchira Kamboj, she did a great work in this particular thing because of the COVID-19. During that time, she made this initiative. She worked on this particular, from India, she made some sorts of COVID secondary data, of course. That is because I tried my best during my PhD. I tried my best to reach them, and I reached few. For instance, when it comes to so many ambassadors, I reached them, but still there is some sorts of limitation to be and to connect with them. So that's. Thank you.
I just have a very minor comment if I can make. I think we should be very careful when we are talking. The constant use of the word guys in the presentation.
I'll take it. I'll work on it. Thank you.
Thank you, Dr. Vijay.
This is an interesting topic to start with. But I think it also highlights multi-level barriers women have, not just at the entry level when you enter into the service, but as you move forward in your career, women occupying the leadership position, there comes lots of other barriers. Right. That's right. So let's move on to the last presenter, Dr. Deksha. Deksha will be presenting on technology could community, gender, and everyday beyond. Right? Okay, that's missing.
Hello, good afternoon, everyone, and thank you to the organizers for this wonderful opportunity to present. As 3 presentations have already happened for our panel, I will be taking all of you back to Uttar Pradesh, which were also the first 2 presentations which we had. So the title of the presentation today is If Technology Could Care, Community, Gender, and Digital Health for Women in India. So sorry. Okay. So this research was actually conducted as part of a larger landscape study in Uttar Pradesh. It was also funded by the Uttar Pradesh government. And we were trying to, through this organization called Samyak, where I was previously associated, we were trying to understand and explore the status of health and healthcare in transitional areas. Areas undergoing rural to urban transition in Uttar Pradesh. And I was earlier associated with the organization Samyak, from where my co-author for this paper, Manisha, is also currently working there as a senior program manager. So I'll just get started. Digital health is increasingly seen as a key enabler for achieving universal health coverage and also meeting our commitments to the Sustainable Development Goals, one of which is enhancing health for all. And this is of specific importance when it comes to strengthening health systems, especially in developing contexts like India. Even when we look at the National Health Policy of India, which the third one from 2017, the policy really advocates extensive deployment of digital tools for improving efficiency and outcome of the healthcare system. There is a lot of focus on integrated health information systems and really promoting efficiency, transparency, and the overall citizen experience of healthcare through the inclusion of digital health. Delivery of better health outcomes in terms of access, quality, affordability, lowering of the disease burden, and efficient monitoring of health entitlements to citizens is really the goal of the National Health Policy. And one of the pathways of this goal is seen as digital health. So this digital health technology ecosystem, which the policy kind of envisages, it includes integrated health information systems, electronic health records, telemedicine, patient health records, the Aadhaar ID, etc. Now, so this is more from the public health and the public system of healthcare lens in the country at present. Looking at the innovations in technology, major improvements in terms of TB diagnostics, cancer screenings, and even behavior change communication, which were all really tough areas for public health to navigate, have seen a lot of contributions from technology, AI-powered mechanisms to really help the public health system through private partnerships to navigate these complex public health challenges. Although a lot of these okay, you've gone ahead. I'm still in the first slide, sorry. Next, yeah. So a lot of these are still in a pilot stage, but they have shown considerable improvements and contributions in that sense. So at a structural level, technology really promises to address the gap in service provisioning, improve access and enhance quality, especially and most significantly for those who've been left behind from the traditional and currently organized public health system as we have today. Next. Okay. So when we look at gender, health, and its intersections with technology, Gender is definitely a social determinant of health, and it has been long recognized as one. And women's health in India continues to be, over the decades, continues to be a policy and practice conundrum, where though we have made significant progress, we still lag behind global and a lot of our own commitments to women's health in that sense. In such a context, digital health technology really kind of potentially promises to overcome the challenge of availability, accessibility, affordability, and quality, which are parameters which really have been the major challenges in women's access and women's achievement of health outcomes across the country. So there are persistent issues in healthcare delivery for women. So the existing, from something as basic as reproductive health to more current challenges of non-communicable diseases, but also the need to kind of embrace technology to prepare health systems for emerging challenges, which would be things like climate change and women's health. So women as digital health technology users, in the last few years, a lot of digital health technology solutions have been targeted and aimed at women. And these include women in rural, urban contexts, in women, English speaking, urban elite women, but also the working class and, women who are beneficiaries of government schemes and government services. And also women who are accessing both private and public healthcare in the country. One of the things that I would want to highlight is that the digital health service provision and women are recipients of care here, but women are increasingly also the care providers and caregivers. So we know that a lot of the frontline health workers in the country are women, and a lot of the digital health technologies which are being employed today are actually being employed through the frontline health workers. So there is a spectrum when it comes to care, health, and digital health technologies, and women are both the providers and the recipients of these digital health technologies. And this is where our paper and study kind of focuses. So as I mentioned earlier, this study is part of a larger landscape study on the status of health and healthcare in Uttar Pradesh. And we wanted to understand women's experiences of healthcare. And one component of it was to look at intersections with digital health technologies. Also because the previous organization that I was working with wanted to roll out some technological solutions for women. So for this, we did qualitative studies with women, frontline health workers, which included Anganwadi workers, ASHAs, ANMs, and community health officers. We had a specific focus on women from marginalized communities. So we were looking at women who came from economically poor backgrounds, and looked at women from reproductive age, women with disabilities, women from different caste and tribe groups wherever applicable, and women who were associated with SHGs and other community groups in the areas. So in total, we conducted 15 focus group discussions. Each focus group discussion had about 10 to 14 women. So we conducted our focus group discussions in 5 Nagar Panchayats. So these were erstwhile rural areas recently declared as urban. And in these 5 Nagar Panchayats, in each Nagar Panchayat, we conducted 3 focus group discussions, 2 with women and 1 with frontline health workers. Oh. Okay. Okay. So when we look at women as care providers, their experience of, and here we mean the frontline health workers primarily, their experience with and their intersection of their work with digital health really kind of talks about their experience of feeling legitimized as women care workers only through technology. And many of them lack the knowledge and skill to really, navigate the technology that has been given to them. For example, one of the quotes that I have here is that every day I spend a few hours updating data and I'm still always behind, always late. And by the time these ASHA workers who are slightly older they learn one thing, the dashboard kind of changes, and things change for them. Again, there is also this concern of duplicity of labor, where they are having to maintain physical registers, multiple registers, and then kind of update data on multiple dashboards. And one of them actually said that, if this was how men work, they would protest and they would never work like this. But just because we are women, it's okay. What the introduction of digital health technologies in the work of the ASHA and the frontline workers has also done is that it has disrupted trust, and it has undermined a lot of the traditional and cultural knowledge that they kind of prided themselves on. And now when they go to doorsteps with iPad, with tablets, they say that doors are closed on our face, and there is, people don't entertain us because they are so worried of what data, where data, etc. And the final point here was that their ownership on the knowledge and data that they collect is being eroded. They don't have any access to the data they collect once it is uploaded on the digitized platforms. And many of them experience a reduction in their role as mere data collectors. When we look at women as recipients of care, the exclusions that happen when digital is the mainstay of seeking healthcare, they are excluded in a very absolute manner. There are no partial exclusions. So in one of the snippets here, one of the tribal migrant worker who would work in a factory said that, if the ASHA finds out I'm pregnant, she will inform my employer, and then I will lose my job, and the 1400 rupees that the government is going to offer is not going to suffice for anything. And this woman eventually delivered at home without any medical, because she was completely left out of the public health system registry. Nothing really happened. Oh, the slides have not moved. Yeah, sorry, the 6th slide, please. Oh, yeah. The 6th one. No, the 6th one. Please, sorry. The next one. Yeah, quickly.
Diksha, quickly.
Yeah, done. Okay, now infrastructures of healthcare and digital healthcare, they continue as gendered sites of intersectional discrimination. Women say that when they go to these public health institutions, to the CHC, etc., the doctor doesn't let us speak. They don't hear our problems. They don't ask for symptoms. They just prescribe medicine. So there's no point of going to the hospital. These are the same sites where digital health technologies, telemedicine, and AI-powered devices are kind of still located, and women find these to be discriminatory and they experience everyday violence in these spaces. Again, there are concerns of women's agencies and patient rights, which they find they associate more with public health institutions than with private health institutions, because they say private में वो कुछ भी free में नहीं करते हैं, public में वो सब कुछ free में करते हैं, तो वो कुछ भी कर सकते हैं. Again, a lot of the problems, I think, as one of the earlier presentations highlighted, a lot of the problems are actually structural, and digital solutions don't do much. Lack of transport, high out-of-pocket expenditures, and women in all of these places continue to rely on informal healthcare providers for their everyday health needs. Next. Okay, so just to kind of quickly conclude, the problem that emerged from our study was that digital health interventions view patients as individuals. In these rural and semi-rural kind of spaces, women's health, their health-seeking behavior, and their access to care is actually navigated through a very complex socio-cultural, community, economic, and structural context. So women don't see themselves as individuals, neither do their families or communities really think of women's health as an individual problem. The digital gender gap exists, and it's really exclusionary. So the digital health ecosystem, which we envisage, must have a it currently has a top-down structure. It prefers standardization over context, infrastructure over people, and it is data-centric as compared to human-centric. Any successful digital health intervention in women's health currently integrating female frontline health workers, but it needs to kind of expand its reach to SHGs, PRIs, CBOs, and women groups and Mahila Sabhas to also focus on digital literacy and co-creation and localization of digital health initiatives through community structures. Yeah, and also that technology should be designed in a way that it empowers women and communities and not eliminate the power and agency of anyone. Thank you.
Thank you, Dr. Richa. Any questions from her?
Can you pass on the mic?
Women are straight away 50% in the population across the world, but I am restricting to India. Why women and women forums do not fight for straight away 50% reservations in educational institutions, employment, and politics?
Yes. The general question.
Am I clear?
Yeah, maybe you can quickly repeat.
Why women and women forums do not insist for pro rata reservations in number one, educational institutions, number two, in employment, number three, in politics, nothing short of 50%. Why don't you raise your voice? Thank you.
Sir, I'm sure a lot of voices are being raised, but I think also kind of borrowing from her presentation that women are far from that kind of political representation at the moment. So a lot of kind of progress on other.
Let her answer, sir.
Yeah. So I would say that sir, those things are part of a very long process, and I would definitely say that women are raising their voices against it. They are just not very loud at the moment, perhaps. However, we don't have to wait for resolutions, or we don't have to really. I think the presentation that I was making was for very basic requirements and like very simple things in life. So it doesn't have much to do with resolutions.
In addition, sir, Article 29(2), where there should not be any discrimination.
then we'll do that. So that is very.
No one will give you freedom until you have to snatch it.
Yeah, that's.
Even if you snatch the freedom and you voice your concerns, who is there to listen? That's also another issue. It's been a prolonged battle. It's not that women are not raising their voices. You know how much battle has gone on to get the reservations in the parliament, and we still are not able to get it, right? Only women, all women, right?
Hello. Ma'am, I would like to ask, like, you told, like, this is also NGO work, and then I just want to know what was the field and what was the urban rural, like, did you map the urban rural thing, and how many districts, or like what kind of data was used, because you did bring qualitative interviews of your participants.
Yeah, so in the methodology section, I kind of did go through it. So the study was conducted in 5 Nagar Panchayats in UP, most of which were located in central and eastern UP. And these are, Nagar Panchayat is a category of the urban, where rural areas which have just been declared urban are in like a transition kind of a phase. So rural to urban transition was the context of the study. However, these places are very recently, turned urban. They've been declared urban. So most of the characteristics of the place as such were, they continued to be rural.
session later. Yeah, one last.
How many ASHA workers got that tablet? Because there
Use
is
your
a
mic.
community workers, there is the digital device. I mean, how many that ASHA workers got the devices like that, tablets or Android phone? Everyone.
So all of them had Android phones.
Yes, and they are provided by.
The ANMs actually had the tab, but the ASHA workers, all of them were working with Android phones.
And that charging recharge also done by that government.
They were given a certain, I think, 300 rupees a month or a certain amount for their recharge.
Are they
Although there were problems, I mean, for some of them, the phones were not working, and like there was a problem with the phone itself, but also some of them didn't know how to use it very well.
That is, they are not friendly. That's
Yeah.
So I would like to thank all the presenters. This session has been a little UP-centric because out of 4 presenters, 3 of them have based their findings from different parts of Uttar Pradesh. So it started off with a very interesting study on the prisoners, women prisoners especially, and their access to various health platforms, especially the digital platforms. Then we have moved on to Akansha, who was also discussing about frontline workers. Both Dr. Diksha and Akansha, both of them tried to focus on frontline workers and their access to digital health technologies, and whether it is equitable access is something they have questioned, and how the data which has been collected through these digital technologies, how is it being used, whether it is being used for the women, whether they have access to the information which is collected by them itself. So these are some of the questions they try to raise. They like to look at the public health systems, the structural issues in the public health systems. So some of these issues were touched by both Akansha and Dr. Diksha. And Dr. Vishaka has touched upon a very different issue. She tried to look at the diplomacy part of it, how many women are entering into the diplomacy sector and how far they have been reaching and how much chances they are being given to voice this health diplomacy is one thing she tried to question. So all in all, I think they have touched on variety of issues, but the similarity which runs through all their presentation again is the kind of access women have to these digital health technologies, the kind of affordability issues which they have to the digital health technologies, and the kind of gender, gender intersectionalities all through, which is running all through the presentations. So thank you once again, all of you. So I stop here.
I would like to invite Dr. K.M. Ziauddin sir to facilitate our chair. And also request to facilitate our paper presenters. Dr. Shazia Farooq Padri. Dr. Visakha Jai. Dr. Visakha Jai. Jha. Dr. Diksha. Akansha Roy. Certificate do it. Before we wrap up this session, I would like to deliver a vote of thanks to the chair and the paper presenters and the audience, and I extend my gratitude to the organizers and volunteers. Thank you once again.
थैंक यू सो मच, बहुत बहुत शुक्रिया आप तमाम लोगों का। आपसे एक बहुत ही ख़ास रिक्वेस्ट है, गुजारिश है, यहाँ से जल्दी जाएंगे, लंच करेंगे। 2:30 शार्प हमें ऑनलाइन का एक सेशन शुरू करना है, आखिरी सेशन, चूँकि ये यूनिवर्सिटी ऑफ लीड्स का एक टीम है, उनको हम लोग बहुत लेट नहीं कर सकते। 2 o'clock हमने कहा था, अभी 2:30 रिक्वेस्ट किया है, तो वी ऑल शुड कम एंड स्टार्ट टाइमली, सो इट दे फील गुड दैट वी आर फॉलोइंग टाइमलाइन। Yeah, thank you. See you all in this hall. Thank you, ma'am, all the panelists.